I'm Dr. Johnathon Ross. I'm a longtime advocate for improved, expanded Medicare for all. Background, I used to be a primary care internist who I taught and practiced internal medicine in affiliation with the University of Toledo's residency program. I'm a graduate of that program and have been up in Toledo since I started medical school, which was in 1972. So I've seen a lot of stuff. I've done a lot of stuff, probably as many things as a physician can do, and including having at one time been an HMO medical director. And so I got to see the dirty underbelly of the insurance industry, whose primary interest is in avoiding sick people, unlike us, where we want to take care of sick people. So this is on the screen is Dennis Yang, and we also have Amanda Fawcett, who is, these are the leaders of the OSU SNAP chapters, Students for a National Health Program, which is affiliated and has board positions on Physicians for a National Health Program. And I'm a past president of that organization in 2001, and have been active in PNHP since 1990, when I became disillusioned with the insurance industry and with healthcare in general, not making any sense to me. So let me go ahead and bring up my screen and share it. And I'm going to go ahead and start the presentation here. The co-sponsors of this program is SPAN Ohio, the Single Payer Action Network of Ohio. We're coming up on our 20th anniversary. We're going to have our 20th anniversary meeting this coming April, on April 23rd, 2022, in Columbus. So if any of you guys are interested in coming, you can check the SPAN website. We plan on having really high-level speakers. I'm hoping that my colleague, Claudia Fagan, who is the head of the entire Cook County hospital system and a longtime PNHP leader, will be joining us to speak, and Dr. Abdul El Sayed, who ran for governor in the state of Michigan and has been an activist in this area. And we are hoping to have one of our significant African-American leaders from Cuyahoga County speak to us as well on the issues around the failure of our system for people of color. So let me go ahead and launch here. We've been at this a long time. I mean, I've been at it since 1990, but the actual genuine effort to create a national health insurance program in America has been around for a century. Teddy Roosevelt had already been president. 1911, he was running it for a second time on the Bull Moose ticket, and had already been to Germany and seen the operating national health insurance program that they had there that was put in place by Kaiser Wilhelm II and Bismarck. And that was already up and going. And Roosevelt actually had that as part of his campaign proposal. Of course, he didn't win. And by the time World War I came around, anything German wasn't going to go anywhere. So those ideas weren't very well received. But there were lots of people in the labor movement who were still interested in a national health insurance program. By the time we got to the Great Depression, Franklin Roosevelt had proposed national health insurance as part of his New Deal, but got talked out of it by Dr. Morris Fishbein, his friend who was head of the AMA. He said doctors would rebel, it would be a mess, and he backed off on that. The worry was that he would lose all the other good things he was trying to do, like the works projects and Social Security and unemployment insurance. Harry Truman was a believer. He actually vigorously tried to pass national health insurance twice. There were bills in front of both the Senate and Congress when Truman was president, and tried twice and failed twice, both times mostly because of pushback from the AMA. Lyndon Johnson looked at some of these things and felt that he could try incremental success. And the reason he chose Medicare and Medicaid is those were the two groups of people who were most likely to not be insured. Medicare, because they were old, and being old meant you could be sick, and the insurers were already not interested in taking on sick people. They want to insure pig iron underwater against fire. They'll never have to pay a claim, right? So the idea of the insurance industry is to avoid, not to help sick people as a rule. And but Johnson was able to push that through with the help of some other the Congress people that were interested. And nobody really paid much attention to Medicaid, which, of course, is a state and federal program that covers mainly the poor and has very comprehensive benefits. The original Truman National Healthcare Plan had benefits that were as rich as the Medicaid benefits. But the benefits are very good in Medicaid in terms of if you can get them. Can you find a doctor who will take care of you? But if you can get a doctor who will take care of you, you've got pretty comprehensive coverage. And they kind of built on that later on, as I'll say, with the Affordable Care Act. Nixon, he thought he was going to be running against one of the Kennedys in his second election, and he needed something to do with healthcare because he knew there were still a lot of problems with uninsurance and costs. And Nixon was mostly interested in costs, and he was the first one to propose HMOs because someone told him that they were doing healthcare for lower costs. So he was all excited about that. Passed the law that said that you had to, if you were a large business, offer an HMO. So the growth of the HMO movement, and that mandatory aspect of it enticed health insurers into the competition that becomes the complexity that becomes the actual cause of our healthcare, excess healthcare costs. And I'll show you lots of information about that complexity. By the time Clinton ran and was elected, we were doing a terrible job having a lot of working people uninsured. We're up to almost 50 million uninsured Americans. He tried but failed, mostly because he had his wife and other experts go into hiding almost and build a plan without talking to any of the Congress people. And the second most powerful people after the president in Washington, D.C. are committee chairs. And the committee chairs in Congress and in the Senate they had nothing to do with what Bill was trying to build. And so it was relatively unsuccessful. It wasn't a great idea anyway. There's this thing called managed competition where you would have your choice of big HMO, A, B, C, or D. And that's where you would get your health care, but at least everybody would be covered. And obviously Obama paid attention. He did not try to create a plan on his own. He turned it over to Congress, and we ended up with incremental but some success by the Affordable Care Act, which did expand a lot of health insurance to the working poor under the Medicare programs. But because Medicare is a state program, not all states accepted it, so it was not as successful as it could be. And then, of course, after that, we got Donald Trump, whose main idea was to repeal the Affordable Care Act. And we never, ever have seen an actual clear-cut proposal from the Republicans for what we should do with our healthcare woes. So I guess the question for all of us is, what's next? Are we going to try more incrementalism, which I think right now that's kind of happening? We're talking about trying to improve the benefits to hearing, dental, and vision in Medicare. People talked about lowering the Medicare age. We're talking about trying to do something finally around pharmaceutical costs. We'll see what we get out of the Democrats this time around. They have a very narrow margin. It's going to be very hard for them to pass anything other than incremental reform. So why are we all stirred up about this? Well, first of all, our costs here in the US are completely out of control. I'll show you the data. Outcomes of care, I say mediocre at best. They're probably worse than mediocre for a rich country. So I'll show you the data. Our access to care is deteriorating, and that's even for people with health insurance now. It isn't just the people who are uninsured that are having a harder time. And we've got a significant chunk of those uninsured still, 30 million, despite the Affordable Care Act. And if we actually looked at the number of people who their deductibles and copays are so high that they can hardly afford to see the doctor, despite having, in quote, insurance, there's at least 40 million people in that underinsured, high risk for bankruptcy category. And again, if we actually canceled the ACA, we'd have 50 million uninsured additional onto what we're already seeing right now. So this is the situation we're in. So let's talk about costs. This is a graph that shows the growth of the percentage of gross domestic product for each of these rich countries. This is from the Commonwealth Fund. Every couple of years for the last 12 years, every 2 years, they've done a study comparing the healthcare systems of the rich nations one to the next. And as you can see, all of us have some increase in the percentage of GDP being spent on healthcare. There's technological advances that are out there, medical advances, equipment advances. All those things are costing the rich countries a little bit more. But what you can see is that we've gone completely out of line with them since around 1980. Well, that's right about the time we began to see the profit motive in health insurance and health insurers focusing on that and competition rather than the old style health insurance, which were Blue Cross Blue Shields, which were community service and took all comers. They refused no one. They had no pre-existing condition restrictions. They did somewhat insure based on age, but again, we had already covered people in Medicare, so that kind of helped a little bit on that end. And they often sold to everybody same basic policy to cover the gaps in Medicare. So looking at this, if you break it down, right now, U.S. public spending, that's the yellow bar at the bottom, pretty much would buy us a national health insurance program. So we're already spending enough in tax and other public dollars to cover everybody. We're just not getting it. And we're still spending an additional, now this is 2017 data, so you probably ought to add $1,000 on almost all of this, although much less than that, again, for the other countries, these rich countries that are listed here. So the bottom line on it is that we're paying for a national health insurance program, but we're not getting it. And again, where are these government dollars coming from? Well, remember that we buy private insurance for all of our government employees. So we're paying extra out of our tax dollars to buy private insurance for our government employees. We're providing tax subsidies, which means when you get health insurance as an employee, you don't have to pay taxes on that money. If you just took after-tax dollars and bought health insurance, you would have had to have paid the taxes on that money. But as a kind of an accident of World War II, we actually ended up with our health insurance tied to our jobs because they had wage and price controls. You could not increase the pay because workers were in such demand that what they didn't allow that, but you could offer benefits. And many of the unionized groups at that time gave health insurance to people as a benefit because they couldn't give additional wages. So again, the subsidies for having no taxes on your health insurance dollars that were paid for premiums. You've got the issue of all the public employees that are in there. And then you just do Medicare, Medicaid, the VA, all those things. I'll show you. Here's the breakout. You can actually see about 10% of our healthcare spending is through tax subsidies. Government worker benefits is 6%. The VA and public health and other public clinics, 11%. Medicaid, 17%. Medicare, 20%. So that's 2/3 of our spending is already out of tax dollars. It's already public spending. So in terms of cost, this is the latest thing that our working people are experiencing. The two lines at the bottom, the bottommost line is the growth of inflation over time from 2009 through 2019. And above that is the increase in wages, which only from 2014 forward has diverged a little bit. We're a little bit better off as working people than we were. But look what's happening with our premiums. Those are going up, up, up. Over time. And then if you actually look at what's happening with our deductibles, they've more than doubled. So people are getting health insurance, but it's less and less usable and much more expensive to them. All of this is happening. One of the reasons these wages are so flat here, the reason those wages are so flat is because the money's going here to premiums and here to deductibles. So what about our outcomes? Well, the latest data just came out a month or two ago from Commonwealth again. This is comparisons. And they look at access to care processes, like are you doing your preventive care? Are you focusing on preventable illnesses? We've got administrative efficiency, equity, and health outcomes, all of which we are right at the very bottom. You can't see us. I guess we're over here. I'm not sure. Let's see if I can negate this window for a second. I don't know if that helps you to be able to see it, but we're 11th in everything other than care processes. We spend a lot of time looking at trying to improve quality when the single most important thing we could do to improve quality would be to cover everybody, at a price that doesn't, bankrupt people. This is another very important comparison that the Commonwealth Fund provides us, which is they look at the preventable deaths, avoidable deaths. And this is what's happened over the last 10 years. This is the percentage reduction in avoidable deaths. These are conditions where if they're properly treated, you should not die. And you can see that Switzerland's had about overall, it's like a 15 to 25% improvement in all these countries: Switzerland, Australia, Sweden, Netherlands, Norway, France, New Zealand, Canada, Germany, UK, all of them, somewhere between, I guess it's 13 and 25% improvement in preventing avoidable deaths. And we've got 5% improvement. And as you can see, we've got the most avoidable deaths per 100,000 of any of them. And I would argue that this is because we don't cover everybody and we provide financial barriers that don't allow people to get the care that they need. Two very common standards of effectiveness of your healthcare system is infant and maternal mortality. Here is a comparison. This is from 2014. This is, again, something that's also in the Commonwealth study. I did not have that graph available, but it's in the latest data. We're looking at a place like Sweden or Italy or Germany having about half the infant mortality. And if you look at maternal mortality, this is almost unbelievable how high our maternal mortalities are compared to other rich countries. I mean, this 12.7 maternal deaths per 100,000 births, that's like almost second or third world country. I mean, this is just horrible, horrible outcome in terms of our ability. And much of it's because we don't provide that sort of cradle to grave care. So if you actually look at the Commonwealth data again, the healthcare system performance compared to spending. So now you've got system performance on the y-axis and spending on the x-axis, and way, way over here out in the hinterlands is the US, completely out of this cluster of other rich countries in terms of what they get in terms of performance for the dollars spent. So we are certainly the lowest value. If you say value is effectiveness for the dollar spent, we are clearly the lowest value healthcare system among the rich nations of the world. And that's just tragic when we could clearly be doing better. Now, access is also deteriorating even for people with insurance. Quick look here at the data on the uninsured. And at the tail end here, we're at 2018, those uninsured have trickled up a little bit. It's about 30 million now. It was probably about 27 million in 18. But the reason it dropped so sharply from 1940 through to 1965 and then dropped again, that's the growth of union health insurance being negotiated as benefits. And so more and more people were becoming insured from World War II, that accident of the wage and price controls leading to higher benefits, including health insurance. And then the growth of the union movement in the US was very vigorous through the 40s and 50s and early 60s. And then we had Medicare and Medicaid, which you can see that next big drop. But very soon afterwards, when we hit that 1980 point again, right after Nixon and the HMO Act, up go the number of uninsured. And a lot of this is because of the discrimination against the sick. Again, the pre-existing condition issues. And again, the increasing costs of American healthcare driving more and more businesses to drop their health insurance. And then right here at 2010, this is where at 2010, we got Obamacare. We had another big drop as we expanded Medicaid. But again, not to everybody. And then up goes the number of uninsured again, and it's crept on from around 25 million all the way back up to around 30 million now, partly because we were being disabled rather than enabled in covering people by the last Republican administration. Now, being uninsured is dangerous. For about every 700 to 800 people who are uninsured, you're going to get one unnecessary death. And if you take all the uninsured in America and looked at what that would add up to in terms of unnecessary deaths, this is data from 2017 in a paper published in the Annals of Internal Medicine. The estimate of these experts, who were also PNHP leaders, was that about 38,882 deaths related directly to being uninsured. Now, that number, about 40,000, that's in the ballpark of how many combat deaths there were in every year of World War II. So functionally, what we have here are excess deaths at the equivalent of World War II, killing people every year, year after year. And to me, that's just unconscionable that we would let that many citizens die every year from something when we obviously could have a national health insurance program that would prevent it. We're spending enough money to have it. We just need to make it happen. Now, one of the things I often hear is, okay, but in these other countries, people have to wait. Well, guess what? We wait too. And although there's a few countries here that wait a tad more, Canada, I guess, is the poster child for waiting. They always seem to come up. But look here, for low-income adults, about the same likelihood that you'll end up waiting more than 6 days for an appointment. We're at 35%, they're at 37%, especially for low-income adults. Their well-to-do people wait a little longer than ours do. And again, many of these other countries, we could go to school on the Netherlands, New Zealand, and Australia and find out what they're doing, because almost nobody is waiting any ridiculous amount of time to get an appointment. And then if you actually look at cost-related barriers to care, that's where we're the champs. And you can see that we're way up there. 43% of Americans say that they, especially if they're low income, say that they've got cost barriers in the past year. And even among people who are not low income, we've got almost a third. And no other country comes close to those numbers. Again, this is pretty preposterous, especially if you look at low income. There's a little bit, there are barriers in those other countries. Again, UK looks like they've got it solved. We could be thinking about how they're doing it. But bottom line on it, we're the worst. And then if you actually add up all these different barriers, not being able to get a medication, skipping dental care or checkups, postponing needed medical care, skipping a recommended medical test or treatment, problems getting mental health care. Those are the percentages. From 12 to 31% of Americans say they've had those problems in the last year. And then if you actually look at, just say, okay, did you have any one of those? Half of Americans said that they had experienced one of those issues. And again, 13% of Americans say that because they face those barriers to care, their condition got worse. And if you took Americans with above average incomes and looked at their access, they're waiting, at least on comparison data. Again, this is from the New England Journal in 2014. I haven't seen any similar exact data to this, but if you look, they're definitely not waiting any longer than we are for an appointment on average across all income levels, but especially they're not waiting if they're above average income, but they're still facing barriers where they can't fill a prescription, they can't get a test, or they didn't get a physician visit. 11 to 17% of people above average means who are still struggling with our healthcare system because of cost. And again, these people have private insurance, many of them, but especially people who have private insurance with high out-of-pockets, high deductibles, co-payments are the most likely to be facing these barriers, again, in the range of 18 to 29% across seeing the usual physician, getting a vet visit, medication, a test or treatment, preventive care, or able to get a visit when they're sick. So the summary on this data is that the current system costs too much, it covers too few, we've got poor outcomes compared to other systems of other rich nations, and mostly, and I'm going to show you this, it's because our sickness care non-system, we really don't have a healthcare system, we have a sickness care non-system. It's financially and administratively hyper-complex and wasteful. Trying trouble with that word. So when you actually look at these things, you should always ask yourself the question, cui bono? Who benefits from having a mess? And so I'm going to show you who benefits from this mess. Anyway, here's the mess again. And this is a kind of a schematic. What we're doing is we got tax dollars, personal premiums, deductibles, co-payments, all this sort of complex funding that's going through private insurers up above, Medicaid and Medicare down below. Also some funding for uncompensated care like our community health centers, all that feeding into the doctors and hospitals, and all the chasing of money that they have to do leads to administrative waste. And certainly there's administrative waste in all the complexity of all the different 1,000 different health insurers with 1,000 different plans, with different premiums, different deductibles, different co-payments. And single payer, it's just better. You got businesses paying taxes, people paying taxes. You could even call that tax an income-based premium. So the rich pay more and the poor pay less, and kick that into a single pool, pay the bills through a single public insurance plan, and it simplifies the collection of the money by doctors and hospitals. To make it even simpler, almost every hospital has to have a budget we should be asking the hospitals to turn in a publicly accountable budget. And if it looks okay, then just send them 1/12 of it. Don't bill anybody. That's what most European countries do. They do not bill from the hospital. This is kind of a joke that was out at the time Obamacare got passed, because this red scribble on the right-hand side of the screen, that was, oh no, we couldn't talk about single payer. We actually tried to talk about single payer in the Senate committee that was handling the Obamacare bill, and we got shut down. People stood up, tried to talk, got arrested. So what we have here is this easy path to covering everybody. Instead, because of all the complexity, we got Obamacare with, there's some silly things there, cat videos in there, I think, and error messages. And anyway, eventually down at the bottom, you get insured if you don't get an orc attack and end up with 15 health points lost. But again, the GOP, no plan whatsoever. Their plan is get sick, die penniless. At least that seems to be it. They certainly haven't proposed one to tell us how we could cover everybody. So here are the boys, and it's usually boys, who are doing the best in this whole mess. They're making regularly between $10 and $20 million a year. This guy on the left, he almost looks like he's high or something. I don't know. And the guy on the, I don't know, rather on the left, no, he's the one that looks like a mobster. And the guy on the right looks like he's high. I don't know. It's year after year, these guys are making this kind of money, and it's almost always guys. And the insurance overhead in the US, just out of the insurance companies, is pretty phenomenal. This is old data again. This is from 2016. So you probably need to project this by about 30% more. But the ratios is what I want to show you. These other countries are managing to provide health insurance to everybody with about 1/4 of the administrative costs. And for us to be spending this kind of money on insurance overhead is preposterous. For example, if you look at the person who's the head of Health and Human Services, who manages all of Medicare and Medicaid, that person makes about $250,000 a year. These guys are making 10-fold that, 20-fold that, 40-fold that, in terms of running a small insurance company that maybe covers a couple million people. We got 70, 80 million people being covered by Medicare and Medicaid. So the bottom line on it is we can get good people to do this insurance oversight without paying people tens of millions of dollars. Let's go to pharma here. So these are the other guys who generally are smiling, although some of them look a little, I don't know, the guy at Gilead looks like there's supposed to be a balm in Gilead, as they say in the Bible. But I don't know. Gilead is the one that invented Havarti. That's or is that the cheese? I don't remember what they call it. Anyway, they invented a medicine to cure hepatitis C. And, obviously that medicine was being charged $70,000 a year. That's kind of like your money or your life, right? With the treatment for hepatitis C. There's no way it costs them $70,000 a year to make that drug. And here's the next, just so you see, this is 2016. Here's the 2018. Again, some of the faces have changed, but the money's the same. We're talking about anywhere from 20, 30, 40, even $100 million for this Regeneron guy. Isn't Regeneron the people who made the antibodies that they gave Trump? I think that's correct. You see how he's smiling. He's very happy. Anyway, so these are making millions and millions of dollars. Some of them, as I showed you, making $400,000 a day. And so we're spending, despite that, almost 4 times as much compared to some other countries, at least twice as much compared to the average European country on our drug spending. And we're doing most of the research. There's very few brand new drugs that are coming out that are actually being produced by the drug companies by themselves without the basic research being done by the National Institutes of Health and the R01 dollars that they're sending to medical schools. Anyway, the bottom line on it is there's no reason why we couldn't get half off on our drugs if we negotiated. We know that's true because the VA is already getting half off on their drugs by negotiating. And look at little Denmark down here. Denmark, I think, has maybe 8, 9 million people. They're getting 1/4 of the cost per capita on prescription drugs. We could have substantial savings, but of course, those guys wouldn't be smiling quite so much. And this, I think, just so you know what their attitude is compared to our attitude, Goldman Sachs asked the biotech research people, is curing patients a sustainable business model. Think about that. Gilead's hepatitis C money, it's going to get rid of these patients, right? They're all going to get cured and they won't need their medicine anymore. So the better business model from their mind is, oh, you should have done what happens with HIV, where you have to take medicines the rest of your life so that you won't die. I mean, that's the way these guys are thinking. That these are the people that are keeping the system the way it is. And, we should not have our healthcare system being run by people who think about treating patients and curing them as a bad business model. Now, the overall profits in the healthcare system, this is from 2019, are just a little over $100 billion. But we're pushing up on spending $4 trillion. So we're talking about the profits that these people are earning from being part of the system is only about 2.5% of the waste that we're seeing. Overall, where we're really wasting money is dealing with the complexity of having to do all the contractual stuff, all the business stuff, all the complexity of billing, all the complexity of networks to provide. These things are all part of the administrative complexity, and that's where most of the money is being wasted. Actually, the Congressional Budget Office did a study of single payer in December of 2020, and they estimated that we're spending $410 billion every year on unnecessary wasteful administration. And that's enough money that you could cover everybody with no copays and no deductibles. It would give us a true national health insurance system. So it's the complexity even more than these profits. I almost might be willing to give them $100 billion to go away. So again, I'm just going to go back and show that 1980 turning point again, because that's real close to when Canada decided, right after the HMO Act, right, up go the costs of U.S. healthcare as a percent of GDP. But Canada decided to do a national health insurance program. And there certainly is growth there, probably 50% growth over the next 40 years. But we've far outstripped that in terms of growth of our GDP, almost pushing up onto tripling it. And again, what they've done is they've kept it simple and they've covered everybody with at least as good or better outcomes. Now, this is another view of that administrative waste. Again, right around 1980, again, you can see up goes this blue line. This blue line are the number of people working in healthcare who are not seeing patients. They're managers working in a managerial or an administrative role. And the growth of administrators is over 3,000% over the last 50 years. Whereas physicians is that gold line at the bottom. We've grown about 200% or so, a little more than 200% in terms of the number of physicians. And that's, a little more than the population as a whole, but it's much more in line with population growth. And the managers are just through the ceiling. So our healthcare system has become a jobs program for paper pushers and bean counters and people like that are chasing the money, trying to figure out how the money can be gotten and who is to pay and who isn't to pay. Okay, let me go forward here. So again, if you look, this is an estimate from a while ago. Again, this is from 2014, but again, it's the proportion that I think you want to see, which is that overall administrative costs per capita in the US are about 4 times those, pushing 5 times those of Canada with a single payer. And again, all that money per person could be spent on providing care and access to care rather than on administrative waste. So we can go to school on these European countries or on Canada and come up with a way to do this without having to spend as much as we're spending now. Or even if, and CBO says, even if we spend what we're spending now, we should be able to cover everybody and still save money. They actually feel that if you covered everybody, no copays, no deductibles, all doctors in, all hospitals in, no networks, you could still end up with the hospitals held whole, doctors held whole in terms of income. You're still going to save $40 billion a year. And their estimates were very conservative. There are other excellent estimates that say we would do even better. So market incrementalism, that's what we've been trying. Everybody, the right wing and to some extent even the center is saying, we need good old-fashioned American competition to drive down prices and improve quality. It works for TVs. Shouldn't it work for healthcare? We've privatized Medicare into Medicare Advantage, for-profit insurance substituting for Medicare. Most Medicaid now is in HMOs that are many of which are for profit. We've privatized our nursing homes. We've privatized and profitized dialysis. People said, well, let's do insurance exchanges. We've already tried those. The Federal Employees Health Benefit System. California has one of those for California employees. We've seen those insurance markets. We've seen insurance markets across state lines. We're not saving money doing that. HMOs, managed care, capitation were all tried. Costs didn't go down. Health savings accounts, high deductible health plans didn't have an impact. Let small businesses associate so that they get better deals, didn't affect the cost. Bundle payments, get the doctors and the hospital to come together and agree on a single payment. I think the at least in the US, the final answer is still not out there, but it's been tried over in Europe, and it really hasn't done much to help control their costs. Pay for performance, very much tried in Europe, especially in Britain and in Netherlands. No real significant cost control. The additional money you end up giving the doctors and the hospitals basically negates the savings. Accountable care organizations, ACOs, that's the latest gimmick. Cadillac tax was an idea that people had too much insurance and you should tax them if they have too good a healthcare insurance. High-risk pools, putting all the sick people off somewhere. And of course, the holy grail for doctors, malpractice reforms. Almost every state has now limited malpractice payouts. So we've been trying all this stuff. And what has happened to our costs? Has it done anything at all? This is all the great ideas from the market forces people. You know, their idea is that you got a square peg trying to fit it into a round hole. And when it doesn't work, they ask for a bigger hammer. And this is what keeps going on here when they're trying to do that pounding. What do we need? This is what we need. HR 1976, that's the Jayapal bill in the House. S 1129, that's the Sanders bill in the Senate. This is the improved Medicare for all model. It would be universal, cover everyone, comprehensive, all needed care, no copays, a single public payer, which would simplify and save tremendous amounts of money on reimbursement costs, getting the money to the doctors and hospitals. It would allow us to improve our health planning. It would give public accountability, and Lord, does this system need public accountability for both cost and quality, but it would minimize the bureaucracy. And it could be done pretty easily. In all honesty, everybody would get a healthcare card assuring payment. Could be a chip card. It could have some very simple but fundamental information like your drug list, your your allergy list, your problem list, so that any place you went, if the doctor plugged that in, they would at least have the basics about you. You could have free choice of your doctor and hospital. The doctors and hospitals would remain independent. They would not be government employees. They could all be not-for-profit and negotiate fees and budgets. If they want to be the hospitals would negotiate budgets either with a national program or with a delegated local planning board. And again, we want capital budgets. We don't want a new MRI on every corner. We need to use the ones we've already got and demonstrate need for more before we do it. And we should be doing a better job approving expensive technology before it goes into common use. Local planning boards could do that, allocate the expensive technology so we didn't end up with an MRI on every corner. And we can use progressive payroll, income, or sales taxes, and it could be a mix of those, to go into a single fund instead of premiums to insurers. And we would keep reserves in case we have a pandemic like we're just going through so that you can handle emergencies. And you'd have a publicly accountable agency whose only duty would be to process and pay the bills. We could even hire one of these old insurance companies or multiple of them, as traditional Medicare does now, to just process payments. And it would be so much simpler. Everybody in, nobody out. And the doctors and patients would be free to get care as they needed and to practice medicine as is appropriate. And this is a ratio, again, you should look at these. This is, again, an older slide. It was not been updated, but I think it gives you the proportions here. And the reason I put it up is because people are talking about a public option again, allowing people to buy into Medicare. Now, Medicare has very low insurance overhead, about 2% goes to insurance overhead versus traditional insurers, which are in the 10 to 15% range. And what you've got is some savings going to that public option. Depending on how many people choose it, you're going to get some insurance overhead savings, but you don't save much of anything on the rest of it. Whereas you get employers who have to manage this complex insurance for their employees, they get a bump because they're not going to have to do that anymore. You get less expensive long-term care because you can budget long-term care facilities. They don't have to bill anymore. Physicians in their offices, the billing becomes simple. And then lastly, hospital administration, same thing. Billing becomes very straightforward, or you don't bill at all because you've got a budget that gives you the money that you need to operate. So you get an operating budget. And then again, the capital costs, you've got to go through an public approval process to spend big bucks to build a new building or put a new expensive program in. This is a separate study. Again, the CBO study is worth looking at. This was done by the Political Economy Research Institute at UMass Amherst, Robert Pollan and his colleagues. And what they found is that if you did a traditional Medicare for all, improved, expanded, you would end up with new expenses. And the way they thought about this, they said, let's take our best data about what would happen when people get covered, how much more care do they use, and let's go at the highest reasonable end that the data would support, which is a 12% increase in utilization. And then let's look the opposite way on savings. Let's be as conservative as possible on savings, looking at the data. And they said, let's see how much we would get in savings. And they're saying we're going to get at least 19% savings using. So that's a high end on new expenses, a low end on savings. You're still saving 7%. And you're going to save this through administration, pharmaceutical pricing, uniform, simple rates that are easy to bill and collect. And you're going to do better on fraud and waste because all the billing is going to come to a single place. And it's just going to be really easier to see who's juicing the system, who is actually, bringing down bucks that seem out of proportion with all the other physicians or out of proportion with all the other dialysis centers or whatever. So again, 12% expenses, 19% savings. They're saying at this time in 2017, when the study was done, we were spending 3.24 trillion. We're pushing up on 4 trillion, 7% savings. That's a lot of money. And we're going to end up with, instead of spending 3.24 trillion, we're going to end up spending 2.93 trillion by that 7% savings. And that's a lot of billions. We're talking about $31 billion. $310 billion every year of savings per the Perry analysis. So the money is there. I guess that's the point I'm trying to make, is that the money is there. And this whole issue of trying to privatize, that private is better, that profit motive leads to better quality and better costs, all of the evidence is against that. For hospitals, HMOs, dialysis, nursing homes, rehab hospitals, Medicare Advantage HMOs, they're all either more expensive or provide worse quality. And that's been looked at in detail and in peer-reviewed journals. So, and we're currently overpaying, in particular, Medicare Advantage plans. They've convinced Congress to give them a kicker, and they've also been upcoding, making their patients look sicker. So Congress has given them a kicker, and they say their patients are sicker when they're not, when we actually get into analyzing it. So we're wasting tens of billions of dollars a year on Medicare Advantage plans instead of traditional Medicare. The same patients, if they were in traditional Medicare, you'd be saving tens of billions of dollars a year. Overall, between 2008 and 2016, this study estimated that we're spending at least $170 billion, almost $174 billion more than we should have on privatized Medicare. Now, this is going to be hard. If we want a national health insurance program that's an improved, expanded Medicare for all, it won't be easy. But we've done hard things. I mean, first thing we had to do is get rid of Britain. And, we had to fight a revolution. People thought we were crazy. They had the biggest Navy in the world, one of the best armies in the world. And we're thinking that we can just get rid of them. And we managed to do it. We fought a war to end slavery. We had a tremendous stress and troubles throughout the U.S. during the Civil Rights Movement to get equal rights for people of color. And they're still attacking that as of today. Women's equality and the right to vote. The movement in the U.S. started in 1848. And it took almost 80 years to get women the right to vote in presidential elections. And there were women who were jailed and beaten trying to accomplish that at the end game. The right to unionize was contested very severely in the U.S. Here in Toledo, there was an Autolite spark plug plant strike. They brought in goons. People died trying to establish the right to unionize. very quickly, we've seen LGBTQ plus rights go from being substantially suppressed. They organized themselves, especially around HIV and the AIDS activists, and now all of a sudden, the right to get married, equal rights in the workplace, all of those things have come to the fore for them. So organizing, you can get things done, even though it's a tough go of it. And for healthcare for all, I think it's our next great civil rights struggle. And the question is will we be involved in that? Will we be part of that struggle? Will we have a healthcare system that meets human rights standards? So I'm going to close with this quote from Frederick Douglass, who was one of the great speakers against slavery. And he was talking about the struggle to end slavery, but I think this fits almost completely in terms of what we're dealing with in healthcare. So this struggle may be a moral one, it may be a physical one. It may be both moral and physical, but it must be a struggle. Power concedes nothing without a demand. It never did, and it never will. Find out just what any people will quietly submit to, and you will have found out the exact measure of injustice and wrong which will be imposed upon them. And these will continue until they are resisted either with words or blows or both. The limits of tyrants are prescribed by the endurance of those whom they oppress. And I think right now, I can't think of can it be possible to feel more oppressed as a physician or nurse in the middle of this pandemic than we feel right now? I think that the cure for that moral outrage, for that moral injury that we're facing in this great battle is to be an activist. So I would encourage all of you who've already joined Students for a National Health Program or other organizations like SPAN, Single Payer Action Network of Ohio, to continue your hard work. This is going to be a lifetime of work. If we accomplish a healthcare system that meets human rights standards, that covers everybody in this country, believe me, if we're spending $4 trillion a year, they will be trying to take it back. So that's kind of where I'm going to close. This is a lifetime of work. I'm sad to tell you that, but get used to it. Because if we want a healthcare system that we want to be patients in, that we want our loved ones to be patients in, that we want to be doctors and nurses in, then we're going to have to struggle. And it may even come to being in the streets if we're going to make it happen. So I'm going to stop the screen share here. This PowerPoint has notes to it. I'm happy to provide it to anybody who wants it. I think I've already sent it to Dennis. So anybody in the Columbus chapter who wants it, but if others want it, they can put a note in the chat to me and we'll go from there. So I'm ready to take questions if people have them. So
John, I can jump in and read a few questions that are from the chat here.
Just quickly, anybody doesn't know, this is Matt Murphy-Jones. He's a family physician, works in a community health center in Dayton, and has been a faculty advisor for the AMSA chapter there in the past. Is that right, NJ?
No, SNAP. Well, actually, no, my wife's the SNAP faculty advisor.
Okay, SNAP. I'm sorry. But. So his wife, Kathy Lambs, is the SNAP chapter faculty liaison. So, and Matt is one of my colleagues in SPAN, as well as PNHP. So Matt, I'm sorry.
That's fine. So so the first question comes from Amy Freeman. She said, when I see administrative costs, I think jobs lost. What would all those workers do for their jobs suddenly? Yeah,
well, that's a very common question. I can tell you when I was practicing medicine and they closed down all the steel plants in my hometown of Lorain, Ohio, and in Cleveland, Ohio, lots of people lost their jobs. And the same people who were all worried about health insurer workers, they didn't seem very worried about what was happening with the steel workers. I mean, I'm sad to say that, but that was kind of my experience. On the other hand, one of the advantages that insurance workers have is that they can read, write, add, and subtract, or they couldn't be in the insurance industry. So if they've got a job as a bureaucrat, as an administrator in the insurance industry or in a hospital, and they're not going to need their jobs anymore, they're educated at a level where it should be pretty easy for them to find a similar job in the rest of our administrative type work within the US. One of the experts who knows about job loss and transfer suggested that the number of people who would lose jobs would be about the number who ordinarily every day in the US or every year in the US, it would be about a third of the number who routinely lose their jobs and find jobs within the US. So I think there's plenty of job opportunity out there for people to move and to find gainful employment rather than to be basically on, parasites, leeches on the healthcare system that are keeping us from getting everybody covered. So now we do within the Sanders bill and the Giant Paw bill, there's actually money in that legislation for training and for support for families that are, I think it goes up to around $60,000 a year, support for families while they retrain or get a new job if they lose their job because of this bill. And the amount of money that we spend doing that is a pittance compared to the savings we'll get by going to the simplicity of a single payer. So that's the answer to the job loss issue, which is
very good.
It isn't such a big problem. It happens all the time in the US, and we're going to support people, unlike what happened to the steel workers.
Yeah, and I think that is, so just to plug SPAN a little bit too, the SPAN state bills both also call for increased unemployment aid and making sure money's for retraining. And if you want more information on it, actually SPAN had an online talk a couple of months ago with labor leaders, both here and in Canada, looking at exactly those issues. And that was brought up then too. And one of the things they brought up is that oftentimes these things are promised to workers when industries are changed around. And we have to make sure, we have to fight to make sure it really happens, because many times they're left out in the cold, and we don't want that to happen for sure. So anyway, you can check out our YouTube channel or our website, spanohio.org.
The lingo for this within the movement is we want to just, as in justice, we want a just transition. We want to make sure that if we go from where we are now, that working people don't get screwed in some sort of way in the process. I don't care about those CEOs that I showed you the smiling faces of. They'll land on their feet. They'll never need to work another day in their life. Some of those guys making $400,000 a day. I'm not worried about them. But I think that support for the line workers in the insurance industry, that's all built into our bills that are currently in front of Congress. And I agree with NJ. We need to make sure that help stays in the bills if we get them passed.
There's a couple of people that have asked definitely for the PowerPoints. One person wanted to see the slide that you had on, I just lost it here, sorry. That was looking at unnecessary death due to lack of health insurance.
Yes.
If you want to reshare that one while we're...
Okay, let me see. I'll go back and do it.
And then while you're finding that one, Tim Bruce asked, would fee-for-service model be maintained with a single payer system?
It can be. It doesn't have to be. It's possible. For example, a lot of doctors are now working in corporate environments where they're already on a salary, and there'd be no reason, if they wanted to stay within that corporate environment, they're happy there, there'd be no reason. You could just have their salaries be part of the budget that the institution, the hospital, or say the medical school is paying them a salary. They could just be institutional and it would be part of their budget. And as long as they weren't ridiculous salaries, then I don't think there would be any issue with it. So yeah, what we're showing here is the number of deaths related to uninsurance. And there's quite a diversity between the states in terms of the percentage of their population that's uninsured. And most of the states that are with the higher numbers of uninsured are states that did not implement Obamacare. So you're seeing actually, as a percentage of their population, a much higher percentage are uninsured, and therefore much higher levels of unnecessary or excess deaths that are probably occurring in those states. And this is all estimated from 1 death per 769 uninsured per year. And that's about what the number has been. It's been looked at multiple times. This is Himmelstein and Wohlhandler, who are PNHP founders. They've done this study. It's been peer-reviewed. It's been published in some of the best journals like Annals of Internal Medicine or New England Journal, where they published their data. And so there's not a lot of debate that being uninsured can be very hazardous to your health. And that's just deaths. This doesn't include injury and disability and suffering and all the other stuff that goes along, and what the impact of that death is on a family or a community. So, you're just looking at yep, okay, that's the mortality, but that mortality ripples through the community, ripples through families, and the adverse effect of that is pretty dramatic. I won't close this down in case somebody else has a question. I need to keep it up. Are you looking at the chat for me?
Yep, still keeping an eye. So somebody asked, is any one industry actively focused on opposing single payer, or is it just day-to-day business for them?
Oh, my gracious. There's a whole AstroTurf group that's being funded by pharma, by device makers, by the insurers, and the Hospital Association was part of it, and the AMA until students within the AMA rebelled and got the AMA to drop out of it. And it's called the Partnership for America's Healthcare Future. Doesn't that sound wonderful? Partnership for America's Healthcare Future. Basically what it is, leave everything the way it is. We're very happy how it is right now. Thank you. And all the people who are making money from the dysfunction of our healthcare system don't want it to change. And
we see that on a state level. Oh, go ahead.
Yeah, the AMA left it this past year when a whole bunch of students said to them, this is, you should not be participating in this. You should be looking for reforms to get everybody covered. And, they had a vote within the AMA, and I think the vote was to leave after this vote to support single payer kind of was pushed forward within the AMA's Congress, and they barely lost, single payer barely lost in the AMA. And I think that made them nervous enough. They thought, hey, maybe we better drop this coalition with the insurers and the hospitals. The hospitals are still in. I don't think they recognize the advantages, although, again, with a very complicated system, we got hospital executives making a couple $1 million a year here in Toledo. I presume that's probably the case down in Columbus or around the state, that we have hospital executives making multiples of hundreds of thousands up to millions of dollars in hospital systems. And partly it's because it's so complex. You need people who understand all that complexity. But the bottom line on it is it could be way simpler. If you had a system where you had an operating budget, you were going to get it every month, and reserves just in case that are in the single payer fund. And the only thing you had to do is actually make your case for, instead of just doing it, you had to make your case for expensive equipment or new buildings or whatever, through a public agency that supervised that. The simplicity of it would mean you'd need people who actually knew more about care processes and how to make a hospital good for patients and good for doctors and nurses, rather than people who know how to make it good in terms of the finances. And so I think there's some fear on the part of hospital executives that they'd see those big salaries go away. I don't know. Either that or they haven't studied the issue, or because they've never looked a sick person in the eyes the way doctors and nurses have to do. They just don't have the same dog in the fight.
And we have seen groups from Ohio. So Colorado had a ballot initiative a couple of years ago for single payer, and Anthem of Ohio, an Ohio-based healthcare or health insurance group, actually spent $500,000 to defeat a Colorado bill because they're so worried that once we get a toehold somewhere that it's inevitable.
Yeah, no, I don't think there's any doubt about it. They want the party to go on. Mm-hmm. Those people, they're making millions, tens of millions, some of them hundreds of millions of dollars a year. And why would they do anything other than support with their money, which they have plenty of, to support the system as it currently exists, that's lining their pockets every day and their friends' pockets. So I'm not surprised that there's resistance or that they're spending corporate money, because now corporations are people, right, in America. So you can spend corporate money lobbying against something like a single payer. So as long as we have the best Congress money can buy, we're going to continue to see a very difficult time. But we have the votes. What we have to do is we have to get people to understand it, and we will have the votes to push this along. We already have over 100 Congress people and at least 24 senators who are in support of this. So we've got a long way to go with the politicians, But among Americans, if you actually poll them, you've got about 60 to 65%, depending on the poll, support for an improved expanded Medicare for all. And it goes up to almost 70%. And this is including Republicans in these polls. It goes up to almost 70% if you tell people that it would make healthcare a right of being a citizen here in the US, and you tell them that it will eliminate insurance company waste. So you get about a 10% bump in the people who support it when you tell them that. So the public's on board with this. The public knows the healthcare system is messed up. Doctors know the healthcare system is messed up. Nurses know the healthcare system is messed up. But, the emperor who has no clothes on doesn't want to admit it. And again, they are the emperors. These are the big money interests in healthcare, and they're going to resist us. And that's why it's going to be a struggle. That's why I put this Stephen Douglas quote up there. But, in some ways, doctors are the DNA. I mean, you can't make another doctor without doctors. So I think that, because we've got, physicians moving more and more in this direction, the most recent national organization that came out in support of single payer were the internists, the American College of Physicians, American Society of Internal Medicine, and the Society for General Internal Medicine have come out in support of Medicare for all as a potential solution to our healthcare woes. They're publicly out on that this past year. So the doctors are coming around. And it isn't just you young people, it's old farts like me. I mean, the fact is that we all can look at the healthcare system because we're in the middle of it and see the problems. I'm noting here from Bob Crazen that, corporate media is funded very well by insurers, drug industry, and hospital conglomerates. That's true. You see the doctor ads the medication, especially pharmaceutical ads, on TV all the time. And when it's time for the privatized Medicare Advantage plans to be trying to recruit people into their hands, you see the ads on TV and in the newspaper. So yeah, there's lots of money being spent by these same enemies of single payer on buying advertisements in the media. And so the media, doesn't want to lose that money either. So it makes it really quite an uphill struggle, but it doesn't mean it can't be done. Again, we've done hard things before. And we can do this.
Speaking of that, another question on there was, have you seen any one event or events where many people joined the single payer cause?
Well, I think that one of the things that we've seen is ups and downs in this whole thing over the years. Absolutely. One of the big ups was during the time when they were debating Obamacare. We got a lot of interest in the press and a lot of opportunity to speak about health reform. So if we're going to go through health reform again right now, we have allies in Congress and allies in the Senate, and I think we'll have another opportunity. The way the CBO report that said that we would spend actually $40 billion less to cover everybody, no copays, no deductibles, any doctor, any hospital you want to go to, pharmaceuticals covered. Only thing that was up in the air was long-term care. But holding doctors whole, holding the hospitals whole, they're paying them the all-payer rates that are currently in existence. So that study, the CBO study, came because we got hearings in the committees of interest on single payer. And that's the first time we've ever had as extensive a set of hearings on single payer as a potential reform approach. And the chair of the committee, where those hearings were held, asked CBO to do a financial analysis of what would be the impact on national health expenditures if we did a single payer. And CBO says we'll save $40 billion a year, cover all residents. They don't even say citizen. Cover all residents, $40 billion saved, go to any doctor, any hospital, keep doctors whole, keep hospitals whole in terms of their income. Now, what I can tell you is that the savings that come from administration from many doctors and many hospitals, they'll get a raise because they're going to save enough on administration. They're going to get paid the same rates for the same patients all the time, and it's going to be the average rate. So if you were in a poverty area where most of your patients were Medicaid and not paying you very well, suddenly your pay is going to go up. If you work in a place like MJ does, a community health center where many patients have no insurance and aren't able to pay, or you've got people who are on Medicaid, the money per visit is going to go up. So actually, the benefit of the administrative savings are pretty substantial. You've got to also remember that malpractice, half of malpractice premiums, maybe not quite half, but it's approaching that. It might be somewhere between a quarter and a half. It's hard to get real solid information on this, but a lot of that money is going to the care of the injured party. And once you've got a uniform, everybody in, nobody out system, you don't need that. It's already covered as in the National Health Program. You've got other issues, you've got other problems, that you might have to pay out because you harmed the patient beyond their health care. But the health care costs come out of your malpractice, and that won't need to be there anymore. And I might also add that almost every insurance that has to cover things that might have healthcare related consequences, your automobile insurance, your homeowner's insurance, product liability insurance, slip and fall for a business, all those things have healthcare in them, and you wouldn't need that anymore. So you're going to get savings in all kinds of other insurance areas that you don't have right now. So, there's a lot of savings to be had by moving to a single payer. And it isn't just in the healthcare system, it's in businesses who no longer have to negotiate healthcare with their employees. They no longer have to manage that for their employees, getting people on and off insurance, adding new babies that are born, adding new family members that maybe have moved in. All these sort of things make the complexity for business pretty substantial. Well over half of what people spend in their personnel offices, in their human resources offices and corporations, is just fussing around with healthcare.
Yeah, and so I guess not really a question, but more of a comment. Somebody said they'd like to see SPAN develop college activists to language this information with their fellow students, as they're the ones that are going to inherit the current system. And I want to second that without a doubt. We are a very old and relatively homogeneous group of mostly old white people. And we are working on trying to reach out more to the young crowd, to more minorities, because that is exactly true. We need to be able to talk to everybody. And a lot of these people, young people, are a tough one on healthcare because they haven't had to themselves usually deal with a lot of it, although some have, of course. But we need all the help we can get. So that's where a lot of you come in too. If you're definitely closer than Dr. Ross and I are to the college days, and being able to reach out to the younger crowd is an important thing.
Yeah, absolutely. I mean, again, a lot of us have been at this a long time, and again, we are getting old, and we certainly are whiter than we ought to be to represent the U.S. population. But we're doing what we're very aware of it. We're trying to increase the diversity. We're trying to reach the groups. I've given this very similar presentation, for example, to the Black Caucus in the Ohio State House a couple of years ago. So, we're doing our best to try and do outreach to people of color and to try and involve people of color in this movement. There's probably, on average, way more for them in this than there is for some of us. But I think it is an issue, and we recognize it and are doing our best to try and address it. So,
I think that
seeing any other chat pop up, I can hang for another couple of minutes here. But again, this will for anybody that wanted to do it and missed it. There will be a video of this up on the SPAN Ohio website. So you'd be able to go back and take a look at it. And I did send the PowerPoint with my notes to Dennis Yang. So he has it. And if you want to email me, I'd be happy to send it to you personally. Just if you do use it in any context, remember to try and credit both Physicians for a National Health Program and SPAN Ohio in the process of using the slides. Just so that you're letting people know where they can turn to at the same time you're using it if they want more information about them. And remember that the notes on there are my notes. This is Dr. John Ross talking in those notes. It's nobody else's stuff, and it's just so these are my comments on the slides, but others might have, a different take on the data. But that's to help you go through it and to understand it a little better and to expand on what you're seeing on the slides. So it's, let's see, I'm going to stop my share. And we got it's 4:12, so we're a little over an hour. I guess, again, if you need to contact me, you can reach me through SPAN Ohio, or I can give you my email. Maybe I should put that in the chat. Should I do that, you think?
That'd be great.
To do?
Yeah.
Okay.
And I think Bob Crazen put a comment in there. If you're in the Columbus area and want to get involved, you can contact him at his email. Again, I'm in the Dayton area, but I'm open to answer any questions as well if people have them.
So if you want to reach me, it's Dr. John Ross at ameritech.net. I put it in the chat so that if you need to,
the person,
you can write it down. But I'm
person who asked
PowerPoint to you. Dennis has it. You could ask Dennis about it. He can send it to you. And again, just if you do use the slides, remember to credit PNHP and SPAN Ohio. And to, if the notes are going to be shared, to make sure that people know that those are my takes and my personal takes, and others might interpret the data differently. In Cincinnati area for use.
Yeah, I'm just getting Dee's number for.
Yeah, okay, good.
So the person in the
SPAN Ohio has a lot of
is
really good activists down in Cincinnati.
And that's her email that I just shared with the chat. So
okay, great.
She's the regional coordinator for the Cincinnati area. Yeah. She's fantastic.
Yeah, so Dee is a nurse, and she's been involved with us for a long time. She's the head of our lobby committee. She's working the state legislators for our state bill. Just so those of you who are still on are aware, we do have a bill that's going to be introduced somewhere in the next month or so. It's been introduced multiple times, but it'll be reintroduced in both the House and the Senate. It's Representative Skindle from Lakewood and Senator Teresa Fetter from Northwest Ohio, who are introducing a state-based single payer. And we've had a financial analysis done of that. And again, same sort of data. We're going to save money for everybody, free you up to see any doctor, any hospital. Doctors held whole, hospital held whole. Dr. Friedman, who did the study for us, is one of the economists at that University of Massachusetts Amherst Political Economy Research Institute. So he's done a number of other state-based studies for us. So we've looked at it state-based. It really makes sense to try to do it nationally. We've already seen what's happened with states when they're involved. It'll be like Obamacare. We'll have states where people aren't getting the health care that they need. And that's just wrong. It's cruel. It's unjust. So I really believe that we should do it nationally. But I think that if we can do a state and prove what we truly believe is going to happen, which is we can cover everybody for no more money than we're spending now and have a better system, I think that would be very hard evidence. And many of the difficult things we did that I had in that list of hard things to do, we managed to accomplish those first in a state. Women first got the right to vote in Wyoming because they needed enough franchise voters to become a state. So they gave women the right to vote so they could become a state. And that happened almost 50 years before women finally got the right to vote in a presidential election. Every state very quickly gave women the right to vote. But of course, that right to vote was to vote for men to be Congress people because it's one person, one vote now. So you actually had more population. So you actually got more Congress people. Senators stayed the same. But little Wyoming, which is still one of the lowest population states, it may be the lowest population state, has 2 senators and a House of Rep. They have more representation in Congress per population than any other state in the Union. And that's kind of an accident of our history. But the rural states and to some extent red states are significantly overrepresented because of the Senate. And the fact that they get as many senators as anyone else in the Senate can filibuster. All right.
Thank you.
What do you think? Call it a day?
I think so.
Oh, brief comment on Massachusetts. Massachusetts is interesting. I mean, they were the first, they did Obamacare before there was Obamacare. Again, states are the laboratory of democracy. Mitt Romney put in an expansion of Medicaid. It's an interesting story. I won't go on to tell you about it, but there was a lady in the state Medicaid office who figured out how to pull down more federal dollars than anybody else had figured out how to do. And she actually got some sort of award for it. So they were already pulling in way more money from the feds for Medicaid. What they were doing, I'll tell you quickly, they were taxing hospitals and giving the money back to them. Okay, so they said, give us we have to have matching money for Medicaid. You give us $100 million of matching money, hospitals. You send us a check, we'll wave it in front of the feds, and they'll send us $100 million of matching money, and then we'll give it all back to you. So, and that became, once that got figured out by a number of other states, the feds put an end to it. But they actually proved that by having a little extra money, they could do a Medicaid expansion, and they did. And they're one of the most highly covered states. I think they only have like 4 or 5% uncovered in Massachusetts right now. And they did it by expanding the CHIP program and funding it very well, by expanding Medicaid and funding it very well. So Massachusetts was pretty sharp in the way they handled things. All right, I don't see any others popping up here. Good enough. So we'll say thank you. We'd love to have students here if you're in the Columbus area. At some point, we'll be meeting in person again in Columbus, and we'd love to have representation. We'd be happy to have students from SNAP be on our state council for SPAN. We want to involve younger people. We want to involve nurses. We want to involve unions. So we're trying to be as diverse as we can be in terms of that and ethnicity. So happy to have SPAN folks from Columbus who are right there be part of our deliberations while we try to move this issue forward in the state of Ohio. All right. Bye-bye to everybody. Thank you so much for listening.